going to give a talk today on diabetic foot in Africa, evidence-based strategies to reduce the amputation rate. Before I start my talk, I would like to thank all the organizers to invite me for this talk, and especially Yamili for repeatedly reminding me and give this talk. Thank you very much. I come from Dar es Salaam, Tanzania, East Africa, which is the land of Mount Kilimanjaro, the biggest Ngorongoro crater, the highest and the largest Serengeti Park, and Zanzibar Stone Town. You are all welcome. Africa and Asia is the largest continent in the world, and if you combine these two developing world, it comes to 76% of the population of the world come from these two continents, and 80% of diabetics are from these regions. So we have the highest burden in our region, and the rest of the world is 24% of the population, which includes North and South America, Antarctica, Europe and Australia. So we have 80% of diabetes from these regions, and we have a double burden. We still haven't finished with communicable disease, and now we are getting to the non-communicable disease. Let's talk about Africa, diabetes prevalence in Africa. In 2000 we were 7.1 million. In 2019 we became 19 million of population of diabetes, and in 2019 it was predicted that in next 20-25 years, that is 2045, Africa will have 47 million of diabetes, which is the highest increase of 143% in the world. So we are going to lead in future in diabetes problem. Let's talk about diabetic foot complications. Worldwide, there is a thorough increase in diabetic complications. Of these complications, foods are predominant and dreadful complications, major public health problems, main cause of prolonged hospital admissions. Cost will not be sustainable for the family and even the society. Commonly have an infectious etiology. Obviously, it is always associated with underlying peripheral neuropathy and peripheral arterial disease. Gangrene and infections are the most common underlying reasons for foot amputations in diabetic patients. True prevalence in our developing world, in Africa especially, remains underestimated because what is happening in the rural area is never ever reported. So we never know what is the actual figure of amputations. Published reports definitely implicates that delayed presentation is an important risk factor, and most of the patients who need amputations die even before the surgery due to infection. As we are all aware that in 2005 it was a diabetic foot year, and we had estimated that an amputation occurs every 30 seconds due to diabetes, which is 2 in a minute. And it was also presented on the front page of the Lancet. Every 30-second lower limb is lost somewhere in the world is due to diabetes. But in 2017 we did again and predicted that now amputation is 20 seconds due to diabetes. So that means from 2 in a minute we went to 3 in a minute. After all these conferences, summits, seminars, workshops, and we have still gone ending up with more amputations. What about economic burden of diabetic foot? I'm going to show you a study which was done in 4 continents, 5 countries, but we are only going to talk about Tanzania. And if you look at it, Tanzania, the rate, we were given this hypothetical case, which was we needed to work on this. How much does it cost? And in Tanzania, you can see it was $3,060, which almost is equivalent to 25 months of salary of that person. Now in developing world, it's an extended family. That means we are more people, more family members, and the bread earner is only one. So it's a huge burden to the family and the community as well as the nation. Let's look at the socio-economic factors. Socio-economic factors, we can see that barefoot walking, inappropriate footwear, like you can see on the picture, home treatment, we usually start at the bathroom surgery, tendency of patients to see the first faith healer or herbal doctors. And here I have one example. This patient had an infection at the toe, and the herbal doctor said that you should use your wife's scalp hair so that the infection should not spread. Unfortunately, what happened in the end, that the person lost the foot and the wife lost all her scalp hair. Then you can see this another example. This here the herbal doctor said mix aspirin with dung, and this is how we saw this wound. Then there are poor living condition leading to rodent bites, lack of awareness among the patients and healthcare workers, and as we are aware that in developing world podiatric service is almost non-existing. Then we have a non-ulcerative pathology of ulcers. These are the causes where we do not examine the patient when they come to the clinic. So they could have a callus or a fungal infections or dry skins and cracks, gross deformity of nails. Why a patient has to reach this stage? Hypertrophic of the nails, traditional marks, blisters and bruises. These are the patients when they come and we do not check their foot, and then it ends up with high morbidity, amputations and mortality. Time is tissue in diabetic foot, and these are the feet which we see here have time is not tissue, and these are the feet which have a history of weeks, months of ulcers, inability to walk, infections and misdiagnosis and treatment. So they end up with amputations and even high mortality. Typical sequential timeline of the patient's decisions to make or to seek a medical help in our settings, mostly in developing world. Patient first initiates the treatment at home, that is herbal bath, use of razor blades or cut the callosities, and we call it as a bathroom surgery. Then they would visit to a herbal or a faith healer or a traditional healer if they see that it's not getting better, and then they go to the primary health center which has got no facilities or a specialty for diabetic foot treatment, and in the end fourth they visit to district or regional health center, and thus by the time patient is finally referred to a hospital, it is often too late to save the foot or even prevent the death. One of the study which we did at our university, Muhimbili National Hospital, and you can see that 15% of them had an ulcer which were admitted. Highlighted words which I have written here are 33% of the patients underwent amputation due to progressive infection, and more than 50% inpatients mortality rate. So they died due to severe foot ulcers. They presented when Wagner was already more than 4. Overall, in this population cohort study, 27% of patients died of this diabetic foot ulcers. And these are the true figures. You can see if you do a literature review all over Africa, high rates of amputations and high rates of mortality. So, what is a practical approach to reduce foot ulcers rates leading to amputation in diabetic foot? Most foot problems are preventable through early identification and prompt treatment by skilled health professionals. And in Africa, the education is the most powerful tool for avoiding the diabetic foots, which is free to the patients. Due to lack of basic education, an ulcer can lead to an infected diabetic foot ulcers and can lead to an amputation. We need education program at least at the grassroots level or a primary care center to prevent complications of foot ulcers in developing world. Education is the only tool we have it in Africa, which is free to the patient. 5 main pillars of preventing diabetic foot ulcers are as follows: regular inspection and examination of the feet and footwear, identification of high-risk patients, education of high-risk patients, relatives, friends, and healthcare workers, which we are doing at the moment with this conference, appropriate footwear for the diabetic patients, which is the most neglected part in our setup, treatment of non-ulcerative pathology, which we need to check every patient when they come for a checking. By implementing these 5 pillars, limb amputation can be reduced by more than 50%. Several successful preventive education programs have been carried out in developed and developing world, and it has been shown, noted, that organized, implemented and published the outcome of education program showed food complication can be reduced by more than 50%. Which people should we target for food care education? This is always a this is always a dilemma for a busy clinic, as we know that we are very busy and we mostly see more 50 to 60 patients in a day with diabetic foot. So we need to create a system where we can not miss high risk food. So this is an evidence-based strategy of service, and if you see, if there is no neuropathy or no PAD, then this is a grade 0 and general information is enough to these patients. Grade 1, if there is neuropathy or PAD, peripheral artery disease, no previous ulcers or amputations, then this one can be checked every 6 months. Grade number 2, these are high risk. These are the people with peripheral arterial disease, with peripheral neuropathy and deformity of the foot. These are the people who need to be checked every 3 months. And the red zone, which is grade 3, highly risk foot, these are the people who had already had a past history of amputation or a past history of ulcers. These people need intensive foot education because these are the high risk foot. Another thing is that education has to be in piecemeal. If you start talking about education, then patient would have a headache. One of these projects which we started was a step-by-step food project which was carried out in Tanzania, and it was pilot study started in Tanzania, the first project in Tanzania. This program showed that ulceration, infections, limb amputations are potentially preventable. As you can see from this slide, these are the food which presented to us, and this was definitely for below knee amputation. But we managed to save this foot, and in the end we put a graft and saved the foot. So let me talk about step-by-step food project which started in Tanzania. And every project which you start, definitely you should ask how to go about, and it is very important to hit the target, otherwise don't start the project. It is also important who you are educating, because if you start giving wrong things, if an educator is not correct, then the student or the food trainer would also start giving the wrong information to the patient. So it's very important that educator should be well educated in sending the right signals. Back in 2003 March, we had a delegation visited in my center, and they had actually come for only 10 minutes, but after seeing these diabetic foot ulcers, they sat for 2.5 hours. I had shown them a lineup of 25 patients, and same time they approved a project, and we said that a task force should be developed, should be set up on diabetic foot in developing countries. So 5 of us, we were invited to India to set up a curriculum for developing world, and this was led by Dr. Carol Becker, late Ali Fosters was in the committee, myself, Dr. Sharad Pansy, and Dr. Vijay Vishwanath. We all sat for 3 to 4 days from the morning till midnight in the night in one room to develop this curriculum. Several meetings were happened, same in 2003, and then we came up with goals and objectives of step-by-step food project to prevent foot ulcers, the amputations. And the goals were to create more awareness of diabetic foot problems, to provide sustainable training of healthcare professionals in diabetic foot management, to facilitate and transfer the information and expertise among the healthcare professionals, that is a cascading effect, and export the ideas to other developing countries. I repeat, and export the ideas to other developing countries to reduce the risk of lower limb complications in people with diabetes, and to empower people with diabetes to care for their feet better, detect the problems earlier, and seek timely help when the problem arises. I was asked to select the teams, and I selected teams. I went for the 15 teams where in those days in 2003 we were the country where we were going to the era of HIV, AIDS and TB, malaria. So diabetic food was very rare. Somebody was responding. So I said, let me start first with the 15 teams, and I selected 11 teams from the main region of Tanzania, and we have 2 islands. The Pemba Island, I selected 1 team, and 3 teams from the Zanzibar Island. The first step-by-step was opened by Honorable Minister of Health, Dr. Hussein Mwini, and now he is a president of Zanzibar, happened to be my colleague. We studied together, he was my colleague. And these are the faculties, and you can see Ali Foster, late Ali Foster's, Dr. Carol Becker, Professor Lutale, Stephen Mobeck, and myself. And it's a 2 years course, basic, and after 1 year advanced course. 3-day course, lectures and workshops are all there. All centers were given education material for patients, nurses and doctors. Instruments were given to all the center as a starter kit, so that when they go back they should not say, oh, we didn't have anything to start. Posters and videos were also given to the centers. These are the workshops. We had asked this team, doctor, physicians and nurses, to come with their big nails of the toe, and they had to cut among each other the nails. You can see this is a workshop to remove calluses and the practice on orange and candles. And when they came in advance, we showed them a live patients, and they were also asked to be a part of it. All the education materials were for doctors, nurses and patients. Posters for the centers, and we also created a poster in a local language, which were distributed in all the centers. Videos for the patients while they are waiting in the waiting room, and healthcare workers videos, because these are the people, when they go back to the centers, they are supposed to cascade the information which they got it from the teaching. This is the instrument tool which were given to all the centers to start as a starter kit, and then they were asked to maintain by the centers. With media, it was very well covered, all the step-by-step food projects by the media. And then in 2006, after doing 2004 and 5 basic and advanced course, in 2006 we randomly went to these centers and checked whether they're really practicing or not. And this was in the mainland. This is in Zanzibar, where there are 3 centers, and this is in other island, Pemba. Due to the successful of this step-by-step project, then we were given to do other step-by-step project, and one of them that it was surgeons. It felt that the surgeons should be trained on salvaging the diabetic food. Program was set up where the surgeons were trained on diabetic food, and it was the unique and the first surgeon project done in Tanzania in 2009. It was difficult for me to ask surgeons to come, being a physician, but then they managed to come, and we had this Dr. Arun Bal who with me, and we created a curriculum for the surgeons. It was again 3-day course which was divided in theory 1 day and 1 day whole day in operation theatre to show them the live patients. Basic course was conducted in 2009 and an advanced course in March 2011. 20 surgeons were trained from same centers which were trained where physicians and nurses were trained. And you can see these are the theoretical workshops which were done, and then these are the operations where the Professor Dr. Arun Bal is operating in the theatre. Some of the surgeons were in the theatre and others saw the direct relay outside seating, how to salvage the food. They were also given a video and the material. So, ladies and gentlemen, all together we had 2 initially 2004 and 2005 basic and advanced courses. Then we had a podiatric courses, followed by another 30 centers, so initially 15 centers and then 30 centers, basic and advanced courses, and then thoracic courses. So here we covered physicians and nurses, about 45 centers, and then we selected surgeons from 20 centers. So before 2004, we had only one foot clinic in Dar es Salaam. That was me who was running it, and then 45 clinics in 24 regions of Tanzania, and then together with surgeons were 20 centers where they had a facility of the surgeons. They became a team of physicians, nurses, and surgeons. We also looked into the effectiveness of step-by-step foot care project in reducing rates of amputations, and the results, if you see over the entire study period 2001 to 2008, the mean annual amputation rate among these patients which were referred to the university hospital was 17.6%. Before step-by-step the trend of the rates of amputations was upward, but by beginning of 2005, amputation rate had increased slightly by 1 standard deviation above the mean. Following the implication of program, the rate of amputation among the referral decreased significantly to a low of almost 2 standard deviation below mean in 2008. And you can see this graph. This was a step-by-step foot project which was done in 2004, and there was a slight increase in 2005, and then it went down to standard -2 deviation. And we saw that foot problems were more picked up and foot ulcers were less, as you can see from the graph, and more patients were healing and total amputations were reducing. And we also had a peer review published papers on step-by-step foot projects. And then it went, as I mentioned when I was giving you an objectives of the goals and objectives of this project, that main idea was also there to export an ideas to other developing countries. So we had about 12 to 14 countries which in Africa it was exported, and step by step was done. And also it went outside Africa, that is India, Nepal, Bangladesh, Pakistan, and the Caribbean islands, St. Lucia and Barbados. But then we said that it is not possible to do step-by-step food project in each and every country of the world, more than 190 countries. So we said that now we should divide this up to according to the regions, 7 regions, and we call it step-by-step change into the food trainer programs to implement step-by-step food project when they go back to their country. So Train the Food Train course is a training program that teaches the course structure, organization, delivery method, and evaluation skill. Train the Food Trainer course is a course run for an expert to train others to become expert when they go back to their country, that is in clinical and education skills and knowledge. And there are 3 parts of the Train the Food Trainer courses: step-by-step basic course, step-by-step advanced course, and implementation and data collection. The first step-by-step food train course was back in 2012 in Brazil, where all the countries of Brazil, all the countries of South America, 14 countries came in Brazil, and when they went back in their individual country, they did it step-by-step food project. And one of the country was Colombia, where this conference is taking place. Then second was in Caribbean island, where we met in Tobago, and where 22 countries came in one country, and then when they went back, they did it step-by-step food project. The third one was in Europe, where we met in Slovenia, and 17 European countries came together, and when they went back, they did step-by-step food project. And the fourth one was in Western Pacific, where 13 Western Pacific countries got together in Thailand, and they went back to their home country to do step-by-step food project. The fifth one was done in Marrakesh, where we targeted actually the North Africa and the African countries which French-speaking African countries, and the sixth one was in MENA region, which was the last one in this series, which we did it in MENA region. 14 countries from MENA region got together in Abu Dhabi, and we did train the food trainer courses, and then they had to do a step-by-step food project. Ladies and gentlemen, step-by-step food project for developing country model. It started as a pilot project in Tanzania and India. All together it started in Tanzania, has been exported to developing world, to the second world, and also developed world in Europe. It is a unique project which started in Tanzania, and now it has already touched 110 countries worldwide, globally. If I have given you too much information and you have lost your way to go about, then, ladies and gentlemen, please, people who are sleeping, can you get up to have a take-home message? Last slide, second last slide to take-home message, which how to prevent food problems. Food examination should be performed in patients with diabetes at least once a year, and more frequently in those at high risk food ulcerations. And we have already talked about that. Who are the high risk food? Identification of patients at risk of ulceration is the most important aspect of preventing amputation. Education, it should be an integral part of prevention, should be simple, repetitive, and should be targeted both what we are doing here at the moment, healthcare workers and patients' relatives. Appropriate food care, which is the most neglected part, especially in developing world, should be given to the patient and checked on regular basis. And treatment of ulcerative pathology, which is because of us if we do not check the food on their annual or 6 monthly or 3 monthly, depends on where the patient is. In conclusions, efforts are still required to increase awareness of diabetes and its complications amongst the healthcare workers and patients. Early detections and treatment of diabetes will definitely improve the course of disease and reduce morbidities, that is amputations and mortality. I would say step-by-step food care project. Our patients with high-risk food are walking step-by-step towards the road to amputation, and by implementing these projects, we wish to take them around step-by-step to the road of safety. Lastly, I would say thank you, the prominent person from Asia, Mahatma Gandhi. He said, live, if you have to live, as if you were to die tomorrow, but learn means educate yourself as if you were to live forever in the world. Second, Nelson Mandela said from Africa, education is the most powerful weapon which you can use to change the world, and he changed the world. And I would say that education is the only powerful tool we have it in developing world, which is free of charge for the patients and effective if implemented properly. Thank you very much for listening. Thank you.